works at Elizabeth Noverna Specialist Center, Singapore, and also provides OSA service to public hospitals in Singapore. He is active in teaching and research and has published several papers and book chapters in the areas of oral and maxillofacial surgery and obstructive sleep apnea. He had also lectured widely both locally and overseas. His special interests are in the fields of OSA, facial aesthetic, 3D orthodontic surgery planning, and 31st orthodontic surgery. And I would like to introduce Dr. Lye to the audience, and welcome Dr. Lye.
Thank you very much. Can you hear me?
Yes.
Okay. All right. Thank you very much. Thank you to Chang Craniofacial Center for inviting me for this talk. And I hope that you will you'll find my experience a little bit helpful in terms of management of obstructive sleep apnea. So I'm just going to share my screen. All right. Okay. Can you see my presentation? All right. Okay. Yes. Thank you. Greetings from Singapore. Thank you all and everyone. Please have I hope you're having a good evening. Today is a Sunday night over here in Singapore. I guess there are many participants from international community. So wherever you are and whatever time zone you're in, I hope that you will find the time spent on this little talk useful. So I've been treating sleep apnea patients for, since 2006 when I did my fellowship in America. And I have actually been taking care of this group of patients, which is quite a challenging group of patients. And I'm very lucky in Singapore to work in both the public restructured hospital system as well as in private practice. And I have had many very expert help in terms of orthodontists, OMS surgeons, my juniors. So I would like to thank all of them for helping me along this path. So today I'm going to talk about the surgical and as well as orthodontic management of obstructive sleep apnea. I'm going to skip past some of the basics, like what is sleep apnea and what constitutes sleep apnea. I think that's basic information, and I didn't include this. So if you find that there is something lacking and you are interested, please go ahead and read up, and hopefully you'll find that this will be helpful. It's a little bit slightly more advanced for surgeons as well as orthodontists. So in Singapore, obstructive sleep apnea is actually surprisingly a strangely important situation compared to when I was in the States, and we were saying that sleep apnea is very prevalent because of obesity. I was in Alabama where 30%, about a third of the population are obese to morbidly obese. But in Singapore, that's even though there's a trend towards obesity, but we are still not very high in terms of the obesity condition. But still, if you look at this study in 2016 done in one of the public hospitals, they found that sleep apnea is very prevalent. 1 in 3 patients of the hospital that were not previously diagnosed were found when they did a sleep study that 1 in 3 have moderate to severe sleep apnea and 1 in 10 has severe sleep apnea. And since we are a multiracial society, we actually found that there is a difference that in the Chinese as well as the Malay community, it is fairly high, and it's actually a bit lower in the Indian population, which facially, structurally, facial structure wise, they are a little bit more similar to the Caucasians. And in that study, they found that craniofacial structure is one of the key determinants of the predisposition to OSA. So in Singapore, I find that many of my sleep apnea patients are both young as well as they are slim. They are not obese and may not even be overweight, but they may have very severe sleep apnea. And I think one of the contributing factor in our population is actually the craniofacial structure. All right, and you can see that the Chinese have been shown to have more severe craniofacial restriction as compared to the Westerners. All right, so I think that will be also a little bit similar to like in Taiwan. All right, so in terms of sleep apnea treatment, all right, I'm not going to go in depth into it, but we categorize them into conservative, non-surgical, and surgical. I do participate in the some of the conservative, referring patients for weight loss, referring patients to bariatric surgeons when they are morbidly obese. And also I deal and I co-manage patients together with respiratory physicians and neurologists when it comes to CPAP treatment. I do treat patients with oral appliance, as well as I have a referral pattern together with other orthodontists, prosthodontists, and even dentists who do oral appliance treatment. And of course, in terms of surgery, today I'm going to concentrate on the skeletal hard tissue surgery. Of course, there are others such as the soft tissue surgery, the nasal surgery, and the electrosimulation of the hypoglossal nerve. All right. So today I'm going to concentrate on the MMA surgery. All right. And I'm going to talk about the orthodontic and surgical aspects and how do we in Singapore over here manage these patients. So MMA has already been well known. It has actually been used for at least the last 30 years to treat obstructive sleep apnea patients. And still there are some classic studies such as this one by Casey Lee, meta-analysis of 627 patients over a mean of almost more than 3 years, 3.5 years study that found that there's 89% success rate, as well as another study in 2015, one in which my mentor, Peter Wade, was involved in, and found that even though there's only a 46.7% of patients reaching complete cure of AHI less than 5, but 83.4% actually attain AHI of less than 15, meaning that they have only mild sleep apnea, which is definitely much better and much less has much less consequences and implications to their health. All right. So when I see a obstructive sleep apnea patient, these are the top processes that I have and how I actually put them into my treatment protocol. So the first, it will be the treatment considerations. That means when I look at a patient who is either referred to me with a previous sleep study, or a patient who is coming to see me because the orthodontist who sees a class 2 patient thinks that the airway looks very small on the lateral ceph, or a patient who is a snorer and is coming to see me. All right, we try to put in all the get all the factors. So the first one will be the patient's complaint, because I see that as the main motivation. If the patient's complaint is the wife pestering them to come here, that is also a complaint. All right, and actually it's not bad because they are going to keep chasing them to see me and to be compliant with treatment. All right, and then there will be support for any surgical treatment as well. Also, we will then assess the severity of the sleep apnea as well as the sleep problem, not just in terms of the oxygen level, but also how is the patient's quality of sleep and how does that affect the quality of life? Because only when you understand that, can you help the patient to understand the importance and how it's going to affect their daily life. A lot of patients, even severe patients, even some of my friends who come to see me, they will brush it off and say, oh yeah, during that period, I wasn't sleeping well, but nowadays I'm sleeping better. All right, but there is a lot of evidence that we will have to share with them, and we will identify the problem so that they will be motivated to look and to get properly treated. All right, so we have to understand the patient, and then we look at the other factors such as the patient factors, such as their age. All right, they can vary. I have patients that goes all the way from teenagers all the way to their 80s. All right, look at their overall health. Nowadays, age and health don't always match. We have 40-over-year-old patients with previous heart attacks. Right, we have 70, 80-year-olds that are very active and very healthy, and they deserve treatment. All right, and also the comorbidities, whether they have diabetes, whether they have a coagulopathy, whether they have obesity, or whether they have any other issues. All right, so all these are important treatment considerations. And then, of course, since we are going going to operate on them, we have to assess their overall craniofacial development to see how much of the factors comes from their facial structure. All right, because facial structure would then translate into the kind of airway that they have. Right. Also, we look at their social soft tissue status, including their nasal airway, including their throat, their tonsil, their palatine tonsil, their lingual tonsils, their soft palate. All right. Any presence of adenoids. All these things we will look at. All right. And also their dental and occlusion status, because if we are going to do surgery, are we going to change their bite, change their occlusion? So we need to be aware whether they have implants or they have periodontal disease, or whether they have partially edentulous. So we need to take all these things into consideration before we start putting it into a plan. And also I put in here is their interest in orthodontic treatment. Some patients are totally not interested and they will say, I don't want orthodontic treatment. I don't want to change my bite. I have no problems with it. All right. Or I am just wearing dentures, just change my dentures after that. Or they may be actually very interested in orthodontic treatment because it's now a path for them to also improve their occlusion and their oral function. So with those considerations, we start the treatment planning. So in my mind, looking at it, that these are patients that are not coming in as teenagers with a skeletal, kind of like a anomaly, all right, facial anomaly with a class 3 bite and wants to improve their occlusion, their bite, their speech, and their facial profile. All right, these are now patients with medical issues. We have to also assess them because some of them would want the treatment early. Right, so surgery first versus orthodontics first approach is something that we have to bear in mind. We do all the due checks, right, and I will definitely engage the whole panel of orthodontists that I work with very often. All right, we will look at medical optimization if they have medical issues. Okay, and then hard and soft palate procedures. During our assessment, we will decide on what hard palate procedures they need, and then whether there are any other soft tissue procedures that will be necessary to ensure a very nice, good patent airway for them after surgery. And when there are hard and soft different procedures, then we have to think about whether we should stage them or we should do simultaneous surgery. Okay, those are my main concern for this is actually safety. And of course, the social impact and the timing involving them, getting them to involve their family to make decisions, be it their parents, be it their children, be it their spouse, and also their social situations. Some of them, because of their job nature, because of the fact that they have newborn babies at home. So we have to take all this into consideration so that we have the least impact on their lives. All right, in terms of a disruption. All right. So in terms of surgical input, what are the information that I require in order to be able to help me to make the plans will be number one, a trial model surgery. I know this is a little bit crude, but literally you will always, as a surgeon, as an orthodontic surgeon, to have two models that we can put together very quickly to do an assessment and to look at the occlusion, the transverse, the AP, all right, to come out and make a very quick assessment and also use that models to actually communicate with my orthodontist. Unfortunately, there is no very, very good and reliable digital version of that I can translate or I can communicate very easily. So I still use traditional models for this, right? But it's just a very quick one. I could either print it out from the intraoral scans or take a quick snap impression, right? Of course, we get pre-treatment x-rays, right? I'll do a nasal endoscopy, all right, and possibly DISE, drug-induced sleep endoscopy, to assess their airway, to look at where the point of obstruction or the level of obstruction that is causing the airway collapse, right? And of course, when it comes to the actual planning, most of the time nowadays we do digital planning. Most of these cases are a little bit more complicated. I do not rely on traditional articulator surgery anymore. Most of them are not going to be single jaw surgery. So CT scan, all right, 3D photos to help me with simulations and a dentition scan, which is actually superior to scanning of the models. All right, so a dentition intraoral scan nowadays is quite available, and most of my orthodontist colleagues have that. And we are also acquiring that piece of equipment as well. And of course, the orthodontist feedback, they are really my left and right hands. They will help me out to prepare as well as to finish up to get a good functional occlusion for the patient. I look at it this way. My concept is that at the very least, what I do in terms of helping the airway is not going to worsen them in terms of their facial outcome, in terms of their occlusion and oral function. At the very least, that should be my main stand. But of course, in addition, we would love to improve it for them, right? Because a lot of these patients, they are a bit older, have other issues as well. In terms of the actual surgical planning, nowadays, I mainly use TrueMatch. TrueMatch is a software. It's the software service together with Materialize and Synthes, such that we will do online discussion with the Materialize engineers. We'll come up with plans, right? We come up with simulation, and based on that, we will actually produce patient-specific implants, right, to help me with the accuracy of the fixation. All right, and it also enables me to do much more complex surgeries where I split the mandible or the maxilla into multiple pieces. All right, and the digital surgical plan is then created, which I will discuss with my patients to show them what I need to do in terms of getting the correct results for them. Looking at the surgical simulation, my main concept, especially for patients who are not very much driven by facial outcome and facial harmony, my main question is that, can you accept this result? Right, most of them have not much problems with it, and as I said, the research and my own data shows that most of the time the results are positive. All right, but there are some patients who will request for slightly different facial outcome if they have a preconceived idea, and some of these patients are younger and they both have sleep apnea and facial deformity, asymmetry, open bite, so they do have other requests as well. So we try to work that all in to get to come up with a customized plan for each and every one of them. Okay, so the plan is then discussed with the orthodontist as well as the patients. And also we will talk about the adjunctive procedures necessary, both dental, surgical, nasal, soft tissue, to put it all in to get the best possible result. Okay, so I'm going to show you some two examples here, right, to illustrate my points. So this is a patient. He's about 40 years old. He is a class 2 patient. He doesn't look very, very class 2 over here. He has severe sleep apnea with a pre-op AHI of 32 and the lowest oxygen saturation of 80%. Right. However, he has a very increased overjet. He actually had orthodontic treatment 20 years ago with extraction of lower bicuspids, right? But he chickened out of the surgery 20 years ago, all right? And then he developed sleep apnea along the way. And so this is his lateral ceph. You can see that his overjet is about 16, all right? And this is his occlusion before surgery. So, and he has a very narrow airway. And this is when we do a nasal endoscopy for him, and then we assess the nasal airway. So we can see on the right side, right, he does have a little bit of a nasal obstruction as well, with a slightly increased lower turbinates, right? So, but other than that, no sinusitis, pretty clear. All right, and then when we go towards the back to the nasopharynx, right, not much adenoids over there, pretty normal, but you can see that his retropalatal airway is very small. His soft palate's already touching the posterior pharyngeal wall, all right, even when he's having just normal nasal breathing, and this is with him awake, right? This is not DICE, right? But we can see that as when we are actually get him to do Muller's maneuver, it actually collapses more. And when we get him to do a mandibular advancement, you can see that the airway will increase quite tremendously. Right, so you can see that is the soft palate, and then here is the tongue base, and you can see that the epiglottis is actually also contacting the posterior pharyngeal wall. All right. Okay. Well, luckily, most of the sleep apnea patients, they are class 2. They are able to protrude quite a lot, and you can see that the retroglossal airway becomes very, very much improved when we are getting the patients to protrude. So we can actually see how that they have, yeah, over here you can see that the left side, there's a little bit of septal deviation, and his left nasal airway is even worse than the right side. Okay, so you can see it's very blocked over here. All right. Okay, so these are some of the assessment that we have to do, right? Even though I'm an orthodontic surgeon, but now we are not actually doing just jaw surgery. We are actually doing airway surgery. All right. And the jaw surgery, the nasal surgery, the soft palate surgery, the throat surgery are all to give him a better airway. So it's airway surgery. And over here, you can see from the plan, from the true match planning, you can see that we have actually decided for his occlusion, and it's definitely positive to actually widen his maxilla, right? And you can look on the left side under the surgical plan. The maxilla is coming forward 5 millimeters. Vertically is the same. There's expansion on the maxilla of about 3.5 millimeters at the first molar. And you can see that the mandible is advanced about 16 millimeters to get him to a class 1 occlusion. And then at the same time, we also advance the chin, all right? And that includes the geniotubercles. And so therefore at Pogonian, we have a total final advancement of about 22.3 millimeters. And this is actually the surgical simulation. So to me, it's definitely going to be positive, but what I want to do is I want to share this with the patient beforehand, just to make sure that they are prepared. Him, as well as his fiance, is prepared that this is going to be the new him. All right, because a lot of these patients are already working adults, and some of them have certain ideas, and you can't always kind of push it down their throat to say that, well, I'm trying to save your life. Whatever you get is what you get. So I run this with my patients to make sure that they are able to accept this, and most of the time they are quite happy too. Right, this is the occlusion, which I actually would then discuss with the orthodontist. So you can see that there's still because this is a surgery first, even though the braces was done 20 odd years ago, this is surgery first, and because there's still a low, quite an exaggerated lower curve of SPE, so we get a pretty much of a 3-point landing situation with maxillary expansion. And then subsequently, based on that, the plan occlusion after surgeries is actually exported out to my orthodontist. And because it's a working adult, a 40-year-old gentleman in the finance industry, he has this opted for Invisalign. So this is the Invisalign planning. So you can see how with the attachment and the orthodontist have planned all the aligners that will come in, and the patient will start the treatment about 3 weeks after surgery. And this is him with a bit of a course correction because of the slightly different overjet after surgery. This was then a additional course correction that was placed in by the orthodontist. Okay, so this is actually how it's done, and every one of my orthodontists have a slightly different technique. Everyone has different degree of embracing surgery first, different degree of embracing Invisalign versus normal fixed orthodontics. So I work with all of them. So this is the patient after surgery, probably about 8 to 9 months after surgery. And we did early post-op AHI of about 10, and his lower saturation is about 82%. And this is his occlusion. His midline is good. His overjet is good. He still has his attachment on. He's on his way to finishing up the whole surgery. The maxilla, you can see that has been expanded to fit the mandible pretty good. All right. And over here, you can see the post-surgical X-ray. You can appreciate the change in the posterior airway space, roughly probably about 3 times the dimension in terms of anterior posteriorly. And you can see, of course, there's quite a lot of hardware placed in. For most of these patients, for the maxilla, I will use a patient-specific implant. So it's a 3D printed titanium plate. For the chin as well. But for the mandible, usually I still do not, I have done patient-specific implants for the mandible, but depending on the situation. Sometimes I have because the advancement is a bit too big for my CNT's matrix BSSO plates, which have limit of about 14 millimeters. I'll show you just another case. It's a slightly younger gentleman, also going for surgery first, Invisalign, because a lot of them wants to get the treatment done because the first focus is actually on their severe sleep apnea, right? But he had, because he was quite a tough case, I worked with my ENT surgeon and we decided to stage his situation. So he had a first stage surgery, septoplasty, turbinoplasty, and U-triple-P. And then subsequently, I came in with the MMA and the lower segmental surgery. Okay, so this is this gentleman, all right? And also, of course, quite class 2, all right? And this is his occlusion, right? He never had orthodontic treatment before, came in like this, class 2, and he has a retained lower right E. But, you know, we decided to do the segmental, keeping the E rather than extracting the E because of the position of the nerve, because of the mental nerve. Right, so this is what we did. This is actually some of the shots from his scope. All right, so you can see it's very, very narrow airway, nasally, soft palate, tongue, everything is narrow. And this is his situation, his not much of a mandible, all right, a very retrusive mandible. Okay, and he also has wisdom, impacted lower right wisdom tooth. And this is his sleep study. This was a watchpad study that was done, and his RDI and AHI is in the 80s. All right. He was slightly overweight, but he wasn't obese. But you can appreciate the tremendous drop in the oxygen saturation when he goes into sleep. All right, so that's a pretty bad sleep study, quite severe sleep apnea, and this was the plan. So again, for him, we advanced his maxillary incisors by 3, but because of the segmental that we were doing, we were advancing the maxillary molars by about 9 to 10 millimeters. All right, and then the mandible came forward. The advancement was about 15 to 17 millimeters, and it was a little bit too long for my standard BSSO plates. So we actually did patient-specific implants for his mandible as well. Okay, and his chin, with the chin and everything else, his Bogonian was advanced about 26 millimeters. So this is the simulation for him, both using the CT scan soft tissue as well as using my 3D photo. So this was then discussed with the patient, and he was also going to have orthodontics and subsequently a little bit of prosthodontic reconstruction of his upper anterior teeth to give him a final nice smile. Okay, and this was the surgical final occlusion that was proposed, that was accepted by my orthodontist with upper segmental, lower segmental, all right? And this was then, for this case, the orthodontist actually did a scan after surgery after about a month when the patient could open wide enough, and then planned the Invisalign. And this is, so you can see the lower right primary second molar that was actually retained. It was actually moved and is actually kept in pretty good position, as well as is actually stable. So this is his occlusion, all right, that was planned, his Invisalign treatment. And this is him after surgery. Good thing, he also lost a little bit of weight. He was actually quite motivated after that. So that was very good. You can obviously see that he has a little bit of nasal deviation from the very beginning, but that was not corrected because it didn't really affect his airway and he doesn't mind, right? And this is his occlusion after the orthodontics, but before he went on to do some veneers for his upper anterior teeth, right? But you can see that all the gaps have been closed. The occlusion is reasonable, all right, for him. And this is his airway before and after surgery. So you can see again, his posterior airway is much improved. All right, you can see on the OPG that you can see that the patient-specific implants was used for the BSSO because of the large advancement of up to about 18 millimeters, or especially on the left side. All right, so this is a double barrel patient-specific BSSO plate. And this was him before surgery and after surgery, the sleep study that was done. His AHI went from 81 down to 3. Still had a little bit of RDI. but he can see that his oxygen desaturation has improved tremendously. And of course, his wife's sleep has improved tremendously. So just to touch a little bit on the orthodontic part, even though I'm not the orthodontist, all right? So for the orthodontic management of these group of sleep apnea patients, that's a slight difference, which I'm going to highlight, all right? Number one, the orthodontic co-management is very important to me, and I pay a lot of attention to it. And orthodontists have a balanced role to achieve good result, right? Their treatment, the orthodontic treatment, is to retain or even improve the oral function after surgery. It's also to fulfill the patient's expectations, but of course, every patient is different. They have different expectations, and that will come into play with in terms of how much treatment time they're willing to tolerate in terms of orthodontic treatment, the amount of effort, whether they want Invisalign, normal fixed braces, their expectation, and of course, on the aesthetics and the functional and the facial harmony is also important. All right, so we have to customize that part for the patients as well. Right. And in terms of orthodontic considerations for this special group of patients, I divided them into patient factors, sleep apnea factors, dental factors, orthodontic treatment factors, as well as surgical factors. For patient factors, right, there's a large age range for this group of patients from 18 up to 80 plus. All right, so they are very, very different, very, very varied. Right, mean age I feel is in my pool of patients about 40 plus. Right, most of them are adults. 70% of them are about adults, working adults with time limitation, and many of them are less dentally motivated. So that means that we have to put in a lot more effort to explain and to motivate them. Luckily, I work with a very, very devoted and good group of orthodontists that help me with getting the patients to go through the whole journey. Health issues are important, or these patients have more medical issues, and they will need to see other medical doctors, be on medication, so they will be exhausted as well. So we need to kind of balance things out. Patient's expectation is very important. In terms of sleep apnea, why is the sleep apnea affects orthodontics? Yes, they do, because a lot of these patients have moderate to severe sleep apnea. All right, they have sleep fragmentation, they have poor quality of life, they have nocturnal hypoxia, they are tired, they are forgetful. All right, so a lot of them also have nocturnal clenching and bruxism. Right, they will break your appliance if you don't take good care and to prevent them from doing that. Right, they also, a lot of them have TMJ pain and disorders that you have to co-manage as well. One additional factor. And of course, a lot of these patients are nasal obstruction, have nasal obstruction, they are mouth breathers, so in terms of their care of their oral appliances, of their braces and all that can be a bit challenging, right? These are pictures from some of my patients, my sleep apnea patients, from severe class 2, periodontal involvement, anterior open bite, very, very hypoplastic maxilla, missing teeth, multiple crowns. Some of them have implants. So they are very, very challenging in terms of dental factors, all right? And some of them have previous dental treatment, orthodontic compensation, right? Very strange malocclusion, right? So all these are very challenging patients that we have to customize and look after, and also sometimes invite other dental professionals like prosthodontists to come in, periodontists to come in on board to manage together, all right? And some of them have caries, all right? And, luckily, I would say most patients, we manage to get them along with the right group of help, all right? Okay. And then, of course, orthodontic treatment factors, they tend to be older patients with harder bone, varying motivation for treatment. Some of them disappear for months on ends, all right? They have work, social, travel requirements, right? They have previous camouflage treatment, right? They usually want surgery first, or at least surgery early, all right? They are a lot of time they're not going to accept doing surgery 2 years later, all right? And we often have to work together with both medical professionals that they are looking after their medical problems, as well as other dental specialists. And compliance is a big issue for these patients as well. In terms of surgical factors, all right, we need to try to prioritize it. So I do sometimes have to appeal to some of my orthodontics colleague and periodontal colleagues to, to try to see what we can kind of combine the treatments to try to get things going faster. The concept for me is more of skeletal expansion for surgery, both in terms of anterior posteriorly, transversely, okay, maxillary expansion, right? And also, because these are the slightly older patients, the concept of expansion for soft tissue support is much more than, reduction, okay? Because the soft tissue is going to sag if you do not have enough support for the soft tissue, okay? And we often have to use segmental osteotomies and adjunctive procedures to help us to get them into the surgery room faster. In terms of my patients, the orthodontic preparation, my main aim is stable occlusion without interference, okay? For fixed appliance patients, right, passive stainless steel arch wires with surgical hooks is excellent, right? Segmentation, to help me with segmentation if I'm planning for a multi-piece osteotomy, right? If the patients are on aligners, well, same thing for lingual braces, but for aligner treatment in Invisalign, as well as the other aligner system, passive retainers is important, and attachments usually are left alone, and I usually will put in micro implants, IMF screws to help me to secure the bite, okay? And in terms of orthodontic preparations, all right, when they come in for surgery, for fixed appliance, I went, if it's surgery first, I want passive bonding with ligature ties, and there are K-wire loops on brackets for me to use to help me, all right, as well as, and for aligners, right, my orthodontists usually use the 3D post-surgical bite plan to create aligners, or if they are not comfortable, then they do post-surgical intraoral scan to create the aligners. And this is usually when I pass my patients to my orthodontist. I don't pass them too early when the patient has a lot of blood, when the patients can't breathe through the nose, when they have a poor bite, when they are in pain. So I like to give my patients to them cleanly, right? But all sorts of different scenarios depending on what kind of orthodontic patterns they are. Usually we restart orthodontics about 3 to 4 weeks after surgery, all right? I get them to at least a mouth opening about 2.5 finger breadth, all right? Oral hygiene can be variable, all right? But stable segments, mucosal closure with no infection, bleeding or pain, and a predicted occlusion. Okay, some of them may have palatal splints, occlusal wafers that because of the expansion, then we keep them in for a while, all right? And also sometimes, as you can see in some of these pictures, they may have presence of skeletal anchorage with micro implants or IMF screws. So what keeps me going after 16 years? These are some of the things that my patients have told me, all right? My wife is willing to sleep in the same room. I've now joined a triathlon. I'm on my way to good health and fitness, all right? Their wives are worried because they don't snore anymore. And some of them will then start sending their wife to see me. Some of them have stopped smoking. They are having good quality of life, good health, all right? So these are the main motivations that I have that drives me towards treating this group of patients, even though they are more complicated, all right? And I am very happy to report that it is still a very fulfilling group of patients to treat. So in summary, I find that orthodontic treatment is an integral part of the skeletal surgery for such patients. General orthodontic principles still remain, but the mindset and goals and treatment goals may be slightly different. And these patients are definitely more complex. And often we have to be aware and also work together with both the medical, surgical, and dental colleagues to help this group of patients. I'd like to thank all of you for your attention. And this is my clinic staff. And if you have any questions, please feel free to email me. And I would love to answer any questions that you have if you don't manage to get the questions answered in the next section. Thank you very much.
Thank you so much, Dr. Lye, for the amazing lecture. Now, at this time, I'd like to invite our panelists for some comments. And our first panelist is Dr. Clement Lin. Dr. Lin? Oh, wait, actually, Dr. Lye, do you mind stopping the share screen first? So, and then I'll pin you and Dr. Lin for the next session.
Yes.
Okay.
Hi, Dr. Lye.
Hi. Hi, Dr.
Thank you
Lin.
very much. Thank
Good
you very
evening to
much
you.
for your comprehensive lecture, and very congratulations to your wonderful results. And I'm thinking about, can you talk about further about the your criteria or selection, how to select patient for surgery first or orthodontic first, and what's your feeling about the outcomes? What's the difference between these two surgical protocols?
Okay, I will try my best to answer this question. Generally, at least in private practice, actually not just sleep apnea patients, all patients actually wants to do surgery first. Unless, of course, they are young, they are schooling, and they want to do it at a particular standpoint after a major exam. But if not, all patients that come to see me, they are always asking, when can we do surgery? All right, so all patients want to do surgery first, but not all patients are suitable. So I would actually have to balance, as I said, get in all the information that I have, which means like my orthodontic colleagues' feedback, patients' social status, their situation. For example, I just saw a patient who wanted to have surgery first, but she's still breastfeeding her baby who is 3 months old. And I said, well, I think number one, the orthodontics may be advantageous to do surgery early because we need some orthodontics to improve the interference. But second of all, please let your baby grow a bit bigger, and I don't really want you to stop breastfeeding for the surgery unless, of course, it's your choice. So we tend to want to do surgery first for these patients because now we have a medical reason, we have a functional reason, but we do look at the limitations, and I do explain to my patients, and most of them are quite understanding.
Thank you. So can we say that you would prefer surgery first more than orthodontic first?
Yes, generally I would say that with our overall protocol, with our patient-specific implants, with our experience and stability, we do get to our predicted occlusion, get very close to it. So most of the time, and my orthodontists, if they are experienced and they are comfortable and they have been managing surgery first, they are quite good to take on that, so to speak, post-op occlusion, because as you probably will know, and you are way more experienced than I am, that surgery first is not really a surgical issue. It's actually an orthodontic issue, right? Because now the orthodontist would have to commit to accept an occlusion that if I deliver the occlusion, they will have to finish it up. They are literally treating a patient that is non-surgical. So in that sense, I have a group of orthodontists that are very comfortable, and they are very comfortable as well as very pro surgery first. And I have a group of orthodontists that they are less experienced, and they definitely prefer to get some of the movement done first, because I will ask them, how will the overjet change? How would the midline change? As you put in the wires, how would the occlusal cant at the canines change? Right? So all these things, if they can't give me an answer, then it'd be maybe better to at least do some early orthodontic preparation to solve some of these issues and question marks first.
Thank you. Thank you very much for your answer.
Thank you.
Okay, thank you, Dr. Lin. And our next panelist would be Dr. Supakit.
Yes, hi.
Hello, good evening.
Hi, yes, good evening. This is Supakit Pianchit Letkajon. I am an orthodontist. I am a faculty member at Mahidol University in Bangkok. I like to say, this is a wonderful lecture, and thank you for sharing your experience with us. I do find your answer to Dr. Lin's question quite interesting, because I think I do agree with your question that whether we do surgery first or not, it's really an orthodontist problem. But from my perspective, whether I choose surgery first or orthodontic first, one of the factors that I decide on is whether, if I perform orthodontic first, would I make a surgeon's life easier? Would I make the surgical procedure a little bit easier or less complicated? So there is that side of the coin as well. Now, I think that perhaps in our audience there may be someone who's perhaps not quite familiar with the MMA and patients with OSA. Can you perhaps step back and maybe talk about your general indication to patients with MMA? Would you prefer that they go through, say, CPAP or auto appliance first, and let's say they fail, and then you would proceed to do surgery? So talk a little bit about that, just so that the audience will get a bigger picture here.
Thank you very much. That's a very good question, and maybe just a little comment about the earlier part. So I do agree with what you say, that the orthodontists, they can actually help make my surgery more straightforward, a bit simpler. And that is always a question that I will always discuss with my orthodontist. If the maxilla is a little bit narrow, is it because it's a dental alveolar of the posterior molars going, tilting inwards, and your orthodontics can expand it out very nicely? Or is it a surgical expansion? So I do want to make things simple. Doesn't mean that I'm a surgeon, means I like to chop it up into as many pieces as I can. All right, I would like stability as well. I do appreciate that. All right, with regards to your questions regarding MMA and choice, okay, there are a couple of things I will just talk about. Number one, of course, is that there are a few criteria. All right, now some of my patients, I operate on them purely for sleep apnea reason. And I also have a lot of patients who have sleep apnea as well as other dental, functional, oral issues. For example, some of them have open bite, some of them have severely worn posterior dentition, some of them are severely class 2 or class 3. So there are different kind of patients. But if it is talking about a pure MMA patient for sleep apnea, all right, what I will say is this. Number one, they have to be at least moderate to severe sleep apnea. All right, number one criteria. Number two, they should have considered, all right, and tried the non-invasive treatment. So even for myself, I would actually send them for CPAP trial. I will work with the neurologist and the respiratory physician to talk to them, to try, go through a trial of CPAP to see whether they are suitable. All right, especially the severe ones. Oral plants may work. I have some patients that have tremendous result with oral plants, but we do all, those of us who are practitioners of that, know that in the severe sleep apnea patient, all right, all patients with periodontal disease who have issues and who have very little protrusion, that a mandibular advancement device may not help them very much. I will, of course, discuss with them regarding that situation as well. So surgery is not always the first thing. There are different patients. Some patients will come in and just say, I am here for a cure. All right, I don't want to use appliance for life. I do not want, whether even if it's a comfortable oral appliance or a very uncomfortable CPAP, but I don't want it. I want a cure. Then there are patients who I would say, try. Please try, and they are undecided. Go for the trial, then at least they know. All right, so that is how I look at their situation.
Okay, thank you. From my perspective, I think, the more that I see patients with OSA, I do think that in younger patients, especially those, in their 20s, in their 30s, I personally push for MMA, much more than I used to, because I do think it's kind of unrealistic to expect that they're going to keep using, CPAP or auto appliance for the rest of their life. So we're talking about a span of maybe 40, 50 years or so. So I personally, use age as one of the consideration as well. Next question, though, when you talk about the two cases that you show us, I was struck by the amount of advancement that you perform, especially in the mandible. Riley recommended approximately 10 millimeters, and here at Mahidol, I think we perform, somewhere in the range of 8 to 10 millimeters. I would say, even less, a slightly less, compared to Caucasian population. I used to practice for a number of years in the US. I talk a little bit about that. Like I said, you chose to advance a whole lot more than what I am familiar with. So is that your average amount of advancement, or your average is much smaller? It just so happened that you chose to severe cases.
Well, what I'll say is this: it is quite a strange situation, and I would say this has been an evolution for me. So when I was in the States and we were doing MMA, yes, most of the time my mentor would say, let's do 10. Let's do 10, 10, we get 10, that's pretty good. All right, if we can't, let's add in the geniotubercle advancement, let's add in the chin and all that. But I found that actually in a lot of these patients, all right, I came up with a new category. The category is called bimaxillary retrusion. All right, so that's something that's not really taught in the textbook. But when we position the patient correctly, some of these patients have bimaxillary retrusion. Just like a bimaxillary, a protrusion, we have these patients. And I would say that over time, that is a surgical technique that we have slowly evolved. And I have advanced the mandible going forward from 10 to 12 to 13 to just the pure BSSSO now. Without distraction, I have advanced it to about 18 millimeters without a chin. So with a chin, with counterclockwise rotation, sometimes we have probably up to 29 millimeters without distraction. And in terms of stability, I've gotten my residents to have a look at it, and the amount of relapse is about 10%. So with a incisor advancement of 17, we are talking about maybe, if the condyles are normal. All right, I do have some patients that I have had with small condyles. They are class 2, and they have open bites already as a teenager, and I've advanced them pretty much, and I've seen relapse. All right, not to the original, maybe about 10-20%, right? But when you have a overjet of 15, and after relapse, we have a overjet of 5, to me, it's still a pretty good advancement. So I take heart in that as this group of patients that I really am very careful with, especially if you have no condyles, and then I would really be talking about bilateral condylar replacement prosthesis. Right, TMJ prosthesis rather than such a big BSSO. But in terms of technical, nowadays we can get 15-16 millimeters stably with the predictable occlusion.
I like the fact that you mentioned the bimax retrusion. It's been my experience in the Asian population as well, that we do have lots of those patients. Unfortunately, that's sort of the preferred type of profile that lots of people would like to have this day. But just to share my experience here at Mahidol during the last 5 years, as I mentioned, we do an advancement of probably in the range of 8 to 10 millimeters, and this is include those BIMAX patients. And I would say our success rate with the AHI less than 10, it's probably close to 100%. We just don't do as big of an advancement as you did in Singapore. Last question, can you, since the 2 cases that you show, they were, skeletal type 2, can you talk about your approach for patients with skeletal type 3? With, say, severe OSA. I guess the tricky part is that, the patients already have, some degree of mandibular prognatism. I could see, some conflicts in terms of treatment planning, whether you would still, advance the mandible further. Can you talk a little bit about that for the audience who may be less experienced in this type of patients?
Sure. Thank you very much for your question. What I'll say is this. Now, in terms of a class 3 patient, I give an example. I have a patient who is sleep apnea, and his overjet is -15. But he was also a cleft palate patient. So my first instinct is, why is the patient class 3? And why is a class 3 patient having sleep apnea? Is it a maxillary midface hypoplasia? Is it a class 3, but because it's actually a lot of rotation, high angle patient, all right? And then you have open bites. So if the patient has midface retrusion, severe maxillary hypoplasia, then we advance the maxilla tremendously. I have advanced the maxilla 14, 15, 16 millimeters using intraoral distraction. But sometimes you have to split the surgery into 2 because I'm still not that good or experienced with maxillary distraction to do the BSSO at the same time. Whereas if it is a pure, real class 3 patient with a normal maxilla and a protrusive mandible, then that patient should have a lot of soft tissue issue. Could be obese, large tongue. So I have a patient who was in such a situation, but she was also a acromegaly patient. So she has a very, very large tongue. So that causes a lot of airway obstruction. So in that patient, we have to do a reduction glossectomy, all right, to try to reduce that at the same time when we did the MMA. So we have to look at it. If it's a patient is morbidly obese and because of the amount of soft tissue, then these patients should consider bariatric surgery, weight loss. But I have patients who are class 3 and we do advance them. And surprisingly, actually, the results are not that bad. I have, but we will have to do more modification, more segmental surgery, so upper and lower segmental surgery, in order to increase the oral cavity volume, as well as to improve the airway space without a significant advancement of the upper and lower lips, as well as the anterior mandible. So there are things that we sometimes do, but yes, definitely very challenging.
All right, thank you. And since we serve the same, type of patients, I hope that we'll have a chance to meet in person in the future. And it's nice meeting you, Eric.
Thank you, and I look forward to communicating with you and to listen to your expertise another day.
Thank you.
Thank you so much, Dr. Supakit. Now, before we head to our next Q&A session, I'd like to invite our last panelist, Professor Low.
Hi, Dr. Lye. It's interesting to listen to your talk, and also very happy to listen to the common discussion and very informational. I do have some question for you, and I am also doing OGS, orthodontic surgery, for patient, mostly non-OSA patient, but occasionally in my patient with occlusal problem, they may have some polysomnography result, such as AHI is 10, and parent worry about and ask me, or some patient not even have any facial type problem or occlusion problem, but with this a PSG result, ask me what to do. And sometimes I look at the patient because the orthodontic surgery design could be different, okay, with or without OSA. And sometimes I look at the patient, the facial type, and ask patient, do you have any clinical problem? She said no. So in this situation, what is your clinical judgment when you design the OGS or when you decide the surgical treatment? Do you look at, when you look at the data, look at the patient clinical presentation, how do you make the judgment?
Okay. Thank you for your question, Dr. Low, Professor Low. What I'll say is this: it is very much a reality, because patients are starting to understand about sleep apnea more often, and patients are getting sleep studies more often. And when they come to see us, they will ask about it, and they may include it in part of their questions. What I'll say is this: if we like you said, we do talk to the patient, we do find out, and also we assess them in terms of their size, their weight, their overall airway, their nasal, whether they have nasal obstruction, do they have allergic rhinitis, are they seeing an ENT surgeon, do they have large tonsils, do they have adenoids, what are there any other issues that's causing them to have mild sleep apnea, snoring. And then the next question we would like to do, because if there are other issues, there's nothing to do with the skeletal profile, right? Because they are class 3, then we have to ask ourselves, should we set the patient back? All right, will we possibly create sleep apnea? All right, then those are the times that we actually have to think about and sometimes take precautions. I give an example. I just operated on a patient who is class 3, is a lady, all right, and she wanted a big change. She wanted her class 3, her upper lip protrusion to be set back quite a lot. And then I'm worried because I say, I look at your airway, it doesn't look tremendous. You don't have sleep apnea yet, but you are in your 20s. If I'm going to set your maxilla back 6 millimeters, I'm going to set your mandible back 9 millimeters, and I look at your airway is only about 7 or 8 millimeters on just a lateral ceph, even though it's just a very simple, but we do worry that will we create sleep apnea? So in that situation, we may have to sometimes talk to the patient to tell them what are the possible issues. If we give you that aesthetic result, that very nice convex profile, but I may end up creating sleep apnea for you. And sometimes I will have to put in certain adjustment. For example, for that patient, I did a setback, but at the same time, without actually causing her to have any negative outcome, I did a genioglossus advancement. I did a Lefort one because she didn't need a upper segmental. I set the mandible back, but I did a hard palate advancement. So in other words, I moved the hard palate forward and I moved the anterior back. So those are some of the modifications that I do. And of course, make sure that she has a proper nasal airway. And then after that, as I said, I warn the patient that these are possible issues. You have to also continue to monitor her weight, all right? And we also want to watch for any signs and symptoms, all right? So all these are the things that as a sleep apnea surgeon, the last thing I want to do is to create sleep apnea. I don't want to create business for myself.
Okay, thank you. I also have some technical problem. I guess you do, when you do two-jaw surgery for the patient with OSA, I think you do mandible mandible surgery first. Am I right?
No, when it comes to because I use very often I use a patient-specific implant, I do the maxilla first. But
Okay.
the advantage is that I do not use an occlusal wafer anymore. I'm
Okay.
actually using cutting guides, and then I'm actually doing an advancement purely based on the mid face.
Okay. So you do the maxilla, the default one first, and fix, and then do BSSO and fix.
Yeah. The
Okay.
issue is that if you do a mandible first, sometimes, and if you are using occlusal wafers, sometimes you don't actually get the advancement that you actually plan for.
Okay.
Whereas if I do it that way, my occlusion will drop back the moment my BSSO is not fixed in the correct position. Because my maxilla will not compensate. There's no give.
Okay. And then my last question is that I saw you have a lot of plate. You mean patient-specific plate. Do you remove the plate after surgery or keep it there?
I would say this, for this group of patients with big plates, long plates, big advancement, sometimes the bone contact and the bone defects are bigger than usual. What I'll say is this, I don't plan to remove the plates. I would say that the only plates I have had to remove, because I have some patients who choose to remove the plates later on, but those that I have to remove are the BSSO plates. Because I guess when the bone defect is very big, sometimes the soft tissue will actually go in towards a bit of the defect. And you will find that when they heal, the bone level is a little bit less predictable when your gaps are 17, 15, 16 millimeters. So in those cases, some of them, that if the plates becomes a little bit exposed, I may have to remove it.
Okay, thank you. Do you have the problem of the pre-exposure in the premaxillary area?
No, so far, no.
Okay.
The main thing will be to plan them correct at the correct level.
Okay, thank you very much.
Most welcome.
Thank you, Professor Low, for your comments. And next, we'd like to head over to the Q&A session. So, Dr. Pryor, would you like to take over?
Okay, the first one is from Dr. Abhijit Choji. He would like to ask, how has been your experience with post-surgical relapse in large advancements? I think you mentioned about like maybe 10%, but could you please explain more?
Okay, so what I'll say is, I would say that in my group of patients, I would say that the relapse rate in my patients with the large advancement, as I said, we've done a study, is actually 10%. But of course, because my advancement can go up to 15, 16, 17 millimeters, 10% is sometimes significant. It can be 1.5 millimeters, all right, at 10%. So it's a little bit definitely more than the normal class 2 patient, where you advance the patient by about 8 millimeters, 9 millimeters. So yes, it's a little bit more, but this is what because I do not actually put in what we call, I do not build in relapse. That means I do not advance more than what I actually need. So in that sense, because I have actually even had a patient who I did MMA for, and because the patient had simultaneous rhinoplasty, and the patient I couldn't put into IMF, the patient actually became class 3. And my orthodontist had tremendous problem. And so what I'll say is that, but when it is about 1.5 millimeters, most of my experienced orthodontists can actually sort that out pretty well.
Thank you. And the second question is from Dr. Karuchiro Ishii. The doctor would like to ask, solid occlusion is the key for stability after class 2 surgery. Is it okay to use aligner? And I think you mentioned about you don't use the occlusal wafer. So maybe you can explain more about this one again.
Okay. What I'll say, you are right. Definitely, you're right that the occlusion is very important, and I do give a lot of emphasis on getting a good stable occlusion as a final outcome. What I'll say is this: the orthodontists that I work with, they come in varied form. I have orthodontists that do almost purely aligners, but all of them are orthodontists. Sorry, but I don't really work surgical cases with normal general dentists, right? Or general dentists that does Invisalign. So I work with orthodontists, and even those who do aligner systems, they have learned how to. So they are a lot of times they're not pure aligners. They are aligners, but with they will ask for micro implants to level the bite. They will put on buttons. They will do sectional braces. Sometimes they will take off the aligners and board up brackets. So even though we say that the original plan was aligners, doesn't mean that all of them will finish fast and finish with aligners. So there is a lot of attention, but as I said, I have tremendous trust for them, and they do whatever it needs to actually get them into that situation. And sometimes, even though the patient wants to finish up with aligners, well, some of them actually are overseas, some of them go overseas for work a lot, so some of them resist other forms. But when it comes to short-term fixed appliance, short-term sectionals to close up certain bites, they are actually, a lot of times, they are actually amenable. So it is, to me, I would say, at least in my orthodontist hands, aligners plus minus with adjunctive other forms of orthodontic treatment to get the final result is actually possible.
Thank you. The next question is from Dr. Chase. What is the advantage of dyes? Can we use CBCT upper airway instead?
Okay, what I'll say is this: dyes has a role. Dyes, drug-induced sleep endoscopy, is a good tool. I would say this now in patients with severe sleep apnea. If you look in the literature, you look at the concept. Now, when it comes to severe sleep apnea, most of these patients have multi-level obstruction. They're not likely to be just a single level. So when we treat these patients, we do actually want to advance and we want to improve their entire posterior airway space, including the nasal airway. All right. So we will do, at the very least, all right, nasal endoscopy, because drug-induced sleep endoscopy has a higher cost and is more resource intensive. And also there are, in terms of you believing how accurate drug-induced sleep endoscopy is, even though, you look at the level of sleep that they are in and you can try to predict. But the question will be is that, are you looking at the worst level? And the question is that may not be the only level. So there is limitation at this point of time. So just like, in some other parts of research, they will do a drug-induced sleep MRI. Would that possibly be better? So that you can look at the response of the soft tissue and the different muscle and the different thickness of or the kind of tissue that the patient have, as well as possibly measuring the tension of the soft tissue. So there are many things that I think is going to improve, and we should keep up with the times and watch to see. But I would say I have patients, especially the more complicated patients, the patients that we are not very sure of where the airway is. For example, if it's a cleft patient, all right, and the patient who already has a little bit of VPI, all right, velopharyngeal incompetence that may affect their speech, then we are very, very careful to see where the obstruction level is. And I think, and these patients, and we will want to do whatever it takes to get as good information as we can so we can plan the surgery. But a lot of the patients, as you can see, like the two patients that I show you, the airway is small everywhere. All right. So doing a drug-induced sleep endoscopy is advantageous, but I don't think it's going to change the fact that we still need to expand the entire posterior airway space.
And the next question is from Dr. Ahmed Taha. If the patient has microglossia associated with hypoplasia mandible, do you manage both at the same time?
Okay, I would say this, I have done it, but I won't recommend it. All right, it is a safety issue. There is a safety issue. I would say that if you have a very good team, you have a good ICU, you have a good team, you have people who can deal with the airway, all right, in case that the operated tongue bleeds, in case the patient cannot open their mouth, you know, you have to make a clinical decision. I would say that for safety, if you plan to do a very significant tongue reduction, all right, and as well as doing jaw surgery, you have to be very careful. And if you are not comfortable, face it. All right, face it. You can do either one first. If you feel that it is like my patient who has acromegaly and the tongue is huge, all right, there's lateral open bites everywhere. All the lower molars are actually bent outwards. You know that the tongue is a big issue, and we may actually look at doing the tongue first, because that may actually improve the situation, and then you can do orthodontics to straighten up the teeth. So you can then do the soft tissue first, and then after that do some orthodontics, and then plan the hard tissue surgery. So it's not a must, because when you have to plan surgical uprighting of the posterior molars, you are doing a complete BSSO with body osteotomy with midline splits. Definitely a lot less stable. So we sometimes have to do heroic surgery, but that should not be something that we should always try for. We should try to avoid hero surgery, because I hope that, you know, all the prominent surgeons here are not going to think that I'm actually Captain America and I'm going to try the hardest possible surgery for the sake of it.
And thank you, Dr. Lye. And I have a question. As
Sure.
Orthodontic residents and learned about the surgical design for OSA patient. You just mentioned about to do the, like, we should consider the transverse dimension. Could you explain more about it? Because when I learned about the MMA surgery, mostly, maybe I will focus on the AP dimension, and their surgeon, Dr. Clementin, he can advance like you, like more than 15 millimeters, maybe 16, 17, 18. But I'm curious about their transverse dimension. Could you please explain more about it?
Well, when we are assessing the patient, well, we do know that, of course, it is actually quite well known nowadays, especially in the orthodontic arena. And I recently, as you, together with you, we attended the Association of Orthodontic conference in Singapore, and there's a lot of things, a lot of interesting information on MAPI, on microimplant expansion of the maxilla, maxillary expansion, and we are not talking about dental expansion, we are talking about palatal expansions and bony expansions. So we do know that actually increases the oral cavity space. It does increase the nasal airway space as well. All right, so what I'll say is that, yes, it is positive in terms of getting the patient more volume, a bigger airway for breathing. So yes, it's a plus. But at the same time, we have to be aware, all right, and balance it out. Because if the patient have large turbinates, all right, should you actually be expanding just to try to get a better nasal cavity? Or we should work with the ENT surgeon to reduce the turbinates, right? And if these patients have also allergic rhinitis, treat the allergic rhinitis. Don't just keep expanding things, all right? We also have talked about how some people expand to the limits, all right? Does that actually help the patient in terms of their oral function? And how do you chase the mandible after that, all right? Even though surgically we can expand the mandible, we can expand the maxilla, we have to question ourselves, it's an extra procedure. There are risks. We may cause devitalization of the incisors. We may actually cause infection. We may create oral nasal fistulas. So we have to be aware. And sometimes, if it's necessary, can we split the procedure? Can we do surgically assisted maxillary expansion? Can we do micro implant assisted maxillary expansion orthodontically, using orthodontics to help? So all these are now choices. And with an experienced team, the surgeon should not be the only person guiding everything. It should be a two-way street. And we should always look at what benefits the patient the most. And if it's going to benefit the patient from maxillary expansion, and the mandible can be expanded as well, all right, with uprighting of lingually tilted lower molars, then of course, by all means, we should try that. And the patient also is younger, want a good occlusion, a good smile. Definitely, it will say that we have different choices.
And I have another questions about the soft tissue management. You say that we should think about the soft tissue expansion rather than soft tissue reduction. Could you please explain more? I mean, like compared to the young and maybe older patient, or what is the situation? Could you please explain more?
Okay, this again is not in the textbooks, all right? And I think the surgeons here will understand what I mean, but we do have patients who are on the older age group. Of course, male versus female, and nowadays doesn't mean that all males don't care about how they look and all females are chasing after plastic surgery all the time. Sometimes you have the reverse. I have some male patients that actually have plastic surgery after my surgery. So I would say this is that when we look at the patient that is in that situation where they are in their 40s, 50s, we have to be aware of what happens to their soft tissue after we have done the surgery. And what I'll say is this, is that is when their soft tissue is starting to lose their own, how should I say, their own the collagen production has reduced, the natural integrity and the support for the soft tissue is now different. So in these patients, I would say that an expansion, an advancement, a transverse expansion actually maintains and prevent facial sagging, jowling for these patients. And when we expand the patient, when we bring the chin forward, we are actually trying to also look at what is their current soft tissue tension, how, what is the age group, how are they going to age, what procedures have they had before, how important they are going to feel regarding this possible issue. So I am very open and I discuss those things with my patient. And if they, I mean, for sleep apnea patients, we almost always advance. All right. But some of them actually say, I do not want too much advancement. I don't want to look like a man, all right, if they are a lady. So we have to try to come to a compromise.
Thank you. Thank you very much for your clear explanation.
All right, I think that concludes our Q&A session. So this means that we should go over to our group photo time. So everyone, please turn on your cameras and we'll take a group photo with Dr. Lye. Okay, so on the count of three, 1, 2. Oh, actually, I think a few more people are popping up. So let's give it a couple more seconds and give everyone time to turn on their cameras. Okay, so I'll count to 3. 1, 2, 3, smile. Now let's go to our next page. Okay, 1, 2, 3, smile. All right, and thank you once again, Dr. Lye, for joining us and giving us such a wonderful lecture. And also special thanks to Dr. Clement Lin, Dr. Supakit, and Professor Loh for joining the panel tonight. And next week at the same time, we will have Dr. Derek Steinbacher to join us and give us a talk on orthodontic surgery, nasal changes, and rhinoplasty. So I hope to see you all next week. All right.
Thank you, everyone.
I'll see you next week.
Thank you very
Bye.
much.
Thank you, Dr. Eric.
Thank you
Thank
very
you very
much.
much.
Yeah, thanks for coming on, and thanks for
Yeah.
inviting me. Thanks for having me.
Very
Yeah.
educational and comprehensive talk. I
Yeah.
learned a lot. Yes.
Yeah, it's great to have someone to walk us through all of this.
No, it's my pleasure. It's I hope that I didn't come across to give because sometimes I do understand that the movement that I make is a little bit extreme, and I do have surgeons who are a little bit worried that this information goes out and everyone is going to go crazy on big
No,
advancement.
no. I totally agree with you. When you do more, you will advance more.
Yes, we
Long
need to.
term.
Well,
Yeah.
we see some of these patients and we look at how small their jaw is and how much soft tissue they have, and I worry all the time when I see big numbers. My biggest number was 111, 113. And I was
Yeah.
like, how am I going to improve you? Because I need to go 95% improvement. And
Yeah.
I'm like, I'm scared.
Don't be scared.
Yes. Okay.
I know you advance a lot. That's really good for those patients.
Yes.
Mhm,
And
mhm.
it takes time to to be able to achieve that in a stable way. And I think I would love to come and meet you, Professor Lin, and learn more from you so that I can help my patients even more.
No. Everyone learn from you.
No. All right.
Yeah, hope the
Welcome,
next
welcome.
time Erica can come join and go present another topic for the audience in ICC. Okay.
All right, thank you. I've actually come to Chang'an before at Taoyuan, and I really enjoyed
Yes.
myself. And well, we hope that one day I can come across again.
Yes.
Yep.
Surely.
Sure.
Yeah. Okay.
All
Okay,
Have a
Thank
good
you.
one.
Much.
thank
you
you.
very
Have a good
much.
evening.
Thank you.
All
Okay.
right.
You too.
Bye bye.
Okay, thank you,
Bye-bye.
everyone. Thank you,
Bye.
Junior.
Bye.
All right.
See you.
Bye-bye.
Bye.
Good night.
Good night.
Okay. Thank you, Junior.
Okay.
Good
Thank
job.
you.
Thank you,
I'll
Prayer.
see you
Yes.
tomorrow.
Okay.
Thank
Tomorrow,
you.
another meeting.
Thank you
in the
so
morning.
much.
Thank you, Prayer. Good
Yeah.
job. Mhm. Okay.
All right.
Bye.